Hello, I'm Dr. Peter Henderson. I want to welcome you here to the Obesity Solutions website. Together, Dr. Robert Richard and I have a combined experience of over 25 years working with bariatric surgery patients. We know about the trials and problems people have in attempting to control this terrible disease. And we know it's a disease. It's not a lack of willpower. And we also know that we have an important tool that we can give you to help you regain control of your life. Because you're here, I know that you or someone you care a lot about has a serious weight problem. What I want to do is to cover all the information that you need about obesity and weight loss so that you can make a good decision to get yourself back on course to a healthier and more energized life. If I can do that, I can feel good about being here and making a difference for you, because at Obesity Solutions, that's what we're all about, is making a difference for you, both physically and emotionally. Right now, we don't know if surgery is the right answer for you. I do know that it's been the answer for hundreds of thousands of people around the world. And you know, every time I go out and do a seminar and I look into a bunch of expectant faces, I get excited because I know that we have something that can help many of you. So to find out if this is the right place for you to be, first let's talk about you. Let me ask you 3 questions. First, have you done the right things and just not been able to lose the weight that you need to lose? Or 2, do you know the right things to do? Or do you just don't have trouble sticking it out long enough to get to where you need to be? Or 3, are you just praying that being here you'll find a solution to the problem? Well, if you answered yes to any one of those 3 questions, keep on going because you're in the right place. Let's talk about obesity. First, it's important to know that you're not alone. Obesity is a major problem worldwide. It affects 25% of the industrialized world. Here in America, about 2/3 of adults are overweight. 1/3 of our children are overweight, but what we're really concerned about are about 10 to 15 million adults who are what are considered morbidly obese. What does that mean? Well, first let's look at the obesity trends over the last several years. I'm going to flip through some slides very quickly, and you can see how obesity is becoming an epidemic problem, particularly here in the South, where we really are fond of our fried chicken and biscuits with sausage gravy. In order to find out if surgery is right for you, first we have to talk about a number called the BMI. This is just derived from a formula that helps us get a measure of how much you weigh in relation to your height. Normal is considered between about 18 and 25. From 25 to 30, you're overweight, but it's not really a serious health problem at that point. Once your weight or BMI gets above 30, though, you're starting to be obese. At 35, it's considered severe obesity, and if the BMI is higher than 40, or if your BMI is actually 35 and you also already have a serious health problem being caused by it, you're considered morbidly obese. And this is important because, as we can see from this chart, as the BMI increases, the risk of premature death increases very rapidly. You can find your BMI. You can either use a calculator here on the website, or you can use a table such as this one. You look down the side and find your weight, look across the top to find your height, and where the lines come together, there's a number. So if your BMI is over 30, continue on because you're still in the right place. If your BMI is less than 30, then we would suggest that you get enrolled in our non-surgical weight loss program. And you can find out more about that by contacting our folks here at the Obesity Solutions. Well, what causes obesity? Well, as I said, we know it's a disease, and it's caused by multiple factors. Probably the most important are the genes that you inherit from your parents. These control hormones that regulate your appetite and how your body uses food for energy. As you can see, it's all very complex, and I won't go into detail right now, but we know that in recent years, science has discovered that there are a number of hormones that are actually produced in the GI tract or in the fat cells themselves that produce effects on your appetite and how your body stores excess energy as fat. Among them are ghrelin, leptin, GLP-1, and adenopectin. Once again, you can see that these interactions are extremely complex, and we'll provide you more detail here on the website so that you can get the information you might want. Some people have what I call the THRIFTY gene. Betty here was able to gain weight on an 800 calorie a day diet. We also know that eating and exercise habits play a big role, as well as your surroundings. Oh, and let's take time out to give thanks to the Big Mac. Fast food industry produces food that is very readily available. My goodness, the drive-thrus are open 24/7, and the food you get there tastes really good. Unfortunately, it doesn't have the kind of nutrition that keeps you feeling satisfied for very long, but you can always go back for a little more. Then there are psychological factors. Many of us eat when we're upset about something, angry or depressed. And it's serious, though, because there are many medical problems associated with the obesity. Probably the worst in my mind is diabetes, which is the leading cause of blindness, the leading cause of amputation. Recently, I read a report that 30% of all hospital charges are related to treatment of complications of diabetes. High blood pressure is twice as common in overweight people. There is an increased risk of cancer, problems with infertility, and fatty liver disease is now the leading cause of liver failure, leading to liver transplants. I mean, it just amazes me sometimes how often people end up needing surgery for the results of their obesity rather than using surgery as the solution in the first place. And you know, it's not just about health. I mean, it's about difficulties with day-to-day living. It's very difficult to walk up a flight of stairs or get in and out of cars. You get tired more easily when you're carrying an extra person around with you. The airplane seats, turnstiles are built for smaller people, so they just don't fit. And if the weight problem gets very serious and your arms can't reach every part of your body, it's difficult even to maintain personal hygiene at times. So what are your choices? Well, there are always the popular diet and exercise programs. You can work with a physician or perhaps a dietitian to change your exercise routines, learn to eat differently. The doctor might even prescribe some medication to suppress your appetite. Everything has been tried: hypnosis, counseling, even wiring the jaws together. And a lot of research has been done about all of these things. And what has been found is that if you look at where people are 5 years after they started one of these programs, there's a 95 to 98% failure rate. In other words, people either were not able to lose the weight, or if they did, they gained it all back, and then some. We call that the yo-yo effect. I'm sure many of you have been there. You know, you lose 20 pounds, gain back 30. Lose 30, gain back 40. And this is hard on your body. Well, back in 1991, the National Institute of Health had a big conference, and they looked at all the available research and found that surgery was the only way to obtain consistent permanent weight loss for morbidly obese patients. Not all gained control, but 70 to 80% had good long-term control, and there are important health benefits that come along with this. As you can see, most of the what we call the comorbid disease problems associated with obesity either go into remission or else are at least significantly improved following weight loss surgery. Well, let's talk about the operations. This chart shows the 4 most common operations done in the United States at this time. Here at Obesity Solutions, Dr. Richard and I do the lap band procedure, the vertical sleeve gastrectomy procedure, and the Roux-en-Y gastric bypass. Another operation that is done in some institutions is called the biliopancreatic diversion with a duodenal switch. It has a lot of complications, or more complications than gastric bypass, and long-term the nutritional problems can get pretty serious. So we don't do that operation in our program. The Roux-en-Y bypass, let's talk about that first. We create a small pouch so that it fills up quickly, but the important thing is that the food travels very quickly into the small bowel. This stimulates the bowel to release some hormones that make you feel full and satisfied. They also stimulate the release of insulin from the pancreas and make the insulin work better. We frequently see diabetics get into remission almost immediately after the surgery. This operation is still considered by many to be the gold standard of weight loss surgery. It has a number of advantages. We know that the weight comes off pretty rapidly. Most people will lose most of their weight within the first year or 18 months. It can be done laparoscopically. In fact, it's been a long time since I did an open gastric bypass. This operation's been around a long time, so we know what to expect in terms of results and what to watch out for. And many of our patients get something called the dumping syndrome. That just reminds you not to eat things with a lot of sugar in them. There are disadvantages. Of course, we're bypassing a substantial part of the digestive tract, so your body will not absorb things like calcium, iron, or vitamin B12 as well, and extra supplements are required. It does require an inpatient stay in the hospital. Most of our folks go home after one night, but occasionally they need to stay longer. It's not adjustable. Once we're done, that's pretty much where you're going to be, and although it can be reversed, it's very difficult and a big, risky operation. It does have some associated risks, and these include leakage, bleeding, dilation of the gastric remnant, that's the lower part that's been bypassed, scar tissue forming strictures, anemia, calcium deficiency, and internal hernias. Deaths do occur, but they've gotten to be very rare, and in fact your chances of dying after a gastric bypass operation are about the same as they are following gallbladder surgery. And it can be very effective. You can see here, and the important thing to notice here is that the medical problems went away and stayed away. So let's talk about the laparoscopic sleeve gastrectomy for a few minutes. It's called a sleeve because we remove the left side of the stomach and leave behind a sleeve-shaped tube there along what we call the lesser curve. The way this works is two ways. First of all, the part that's removed produces that hormone called ghrelin. That's what makes you hungry when you lose weight, and so after that's gone, people are able to lose weight comfortably without feeling like they're starving to death. We don't change anything about the bowel, so the course of the food through the GI tract is not changed. There are no implanted devices, and one other thing is that this can be done pretty readily in really large people, and so we think even if somebody might need a second operation later, it's a very good place to start. There are some risks. Leaks do occur. They're very uncommon, but when they happen, they're pretty serious. Narrowing, strictures, bleeding, but as you can see, the death rate following this operation is about half as high as the gastric bypass. Very, very rare. So the advantages, it doesn't really require any disconnecting or reconnecting of the bowel. And you know, we found that the weight loss is very similar to what we see after the gastric bypass, which is a considerably bigger operation. We don't have to implant any new devices, and so we think it's safer than the gastric bypass for very large patients. We also preserve the pylorus muscle at the lower end of the stomach so people don't get the dumping syndrome. Although it hasn't been around as long as the gastric bypass, we're beginning to get information that shows that actually the weight loss does hold up really quite well. But there are a few people who may need conversion to a gastric bypass later on. We don't see that very often at all. Here are some before and after pictures. As you can see, this gentleman would just about swamp his boat when he went fishing. He went from about 500 pounds down to 220 and is feeling great. Now let's talk about the lap band just a little bit. This has been around since 2001. The Food and Drug Administration approved it at that time, and they called it a real breakthrough, which means it substantially reduced risks, complications, and hospital stays. And you know what? Just last year, they actually approved its use for people with a BMI of 30 if they've already got diabetes or high blood pressure or a serious condition. The way it works is we put this band around the upper stomach. This is really a purely restrictive operation. It just reduces the amount of food your stomach can hold, and it slows down the emptying, so you feel full faster. You can have a Crystal Burger, feel like you just had a Big Mac. The best part, there's no cutting, no stapling, and we do it laparoscopically. So it's less invasive, and there's a much lower risk of leaks or infection. I think it works because the pressure on the outside of the stomach fools your stomach into thinking it's got food in it so that you don't get hungry in between meals. It is adjustable, so as you lose weight or have different needs, we can either add fluid and tighten it up or remove some if necessary. It's an outpatient procedure for almost all of our patients, and most people lose about 45 to 50% of their extra weight within the first year after their surgery. And I just read a report yesterday that showed that this is holding up very well out over 10 years. Now, it does require an implanted medical device, and you got to come see us pretty often and see our smiling faces. This only really works pretty well if we see you about once a month for the first year or year and a half and adjust it as frequently as necessary. But overall, it does have the lowest risk of serious complications, and as I say, it's the least invasive. When the band is well adjusted, we look for folks to be losing about 1 to 2 pounds a week and not getting hungry between meals. They got to chew very thoroughly, but they can pretty much eat normal food. There's really no limitation on liquids, although we really discourage people eating or drinking things with a lot of calories in it. So you're going to have to give up the milkshakes in your beer. There are risks. They're usually not life-threatening, but the port can create problems. There can be infections. The stomach can slip up through the band. Once in a while, it erodes to the inside, and it can cause obstruction. And the esophagus or the pouch can dilate up to hold more food. But as you can see, the death rate is almost non-existent, probably less than 1 in 1,000. Now, Robin was one of my band patients. She lost about 80 pounds in the first 9 months after her band was put in. That's not really typical. Most folks she did not need an adjustment, but most folks will need 5 to 6 adjustments within the first year. Bridget lived a life that was just dominated by thoughts of food before her band, and her band allowed her to gain control, and she has maintained her weight loss very well for 5 years. Here's a chart that shows a comparison of the 3 operations in terms of how the weight comes off. The green line is the band. As you can see, it comes off more slowly than the other 2, but it continues to come off over a longer period of time. So 3 years after the band's put in, there's not as much difference as you might think. Here's a comparison of the recovery times. As I said, the band is generally an outpatient procedure. Many of our folks will have their surgery on Thursday or Friday and be able to go back to work on Monday if they don't have to do much heavy lifting. The other operations are a little bigger, require generally 1 night in the hospital, and may take a little longer to get back to work. So let's compare our choices. First, you could do nothing. And I'm not trying to be sarcastic here. Many people are just not ready for surgery. Of course, the long-term effectiveness is pretty much 0, but that may be an advantage, that there's no change in your life. Of course, that's the disadvantage as well. Popular diet, exercise plans, well, we've seen that they're not very effective. An advantage, though, is they're readily available and you can start any time. It's always next Monday. The disadvantage is the yo-yo diet, which puts a tremendous strain on your body, and they tend to be pretty expensive if they're effective. Comparing that to the surgery, well, we've seen that long-term the control is much better. It tends to be a permanent solution, and it targets the cause and teaches your body to live happily with less food. The main disadvantage, it is surgery, and we know that surgery carries some risks. The risks are there, but in general, they're much lower than the risk of not having surgery and carrying the extra weight. These are the risks of our operations. As you can see, they're there, but they're very low. And let me remind you of the risks of obesity itself. In general, this is much higher than the risk of having an operation. This is a study that was published in the New England Journal of Medicine. 40% decrease in death from any cause, 60% decrease in the deaths from cancer, 92% decrease from diabetes. Still, it's a huge decision. It's like getting married. It's like having children. There are big changes to be made, and they're not easy to make. Many people worry about finances, and there are some out-of-pocket expenses. Even when your insurance covers it, there are deductibles and copays. And if you contact our office, our coordinators will be happy to review your insurance plan to let you know exactly where things stand. Of course, you'll have to do some shopping unless you saved all those clothes that you used to fit in. Well, why are we special? Why would you want to work with us? I think, as I mentioned earlier, we have experience with thousands of bariatric cases, over 25 years between the two of us. We've done over 1,000 adjustable gastric band operations and hundreds of sleeve gastrectomies. I think one of the things, though, is our very thorough preoperative education process. This seminar is the first step, but then, again, it's about aftercare, and particularly for our band patients, but important as well for gastric bypass and sleeve patients. It's important to maintain contact with your surgeon and for frequent visits, and it's necessary. We also offer support groups, several of them. You have one that meets every Tuesday. We also have one that meets on a Saturday morning and on a Thursday morning. I don't know of any other program in the country that offers this much in support. So in summary, we've talked about obesity, its effects on you and your health. We've compared the effectiveness of the surgical approaches versus non-surgical approaches to management. We've discussed the 3 operations that we do. So, a year or two from today, when you look in the mirror, I truly hope that you see the healthier, happier person that I think everyone deserves to be. And as you continue your journey, if you decide that surgery is something that you would like to pursue or even just want more information about, please contact us here at Obesity Solutions, because we are here to help, and we hope that we can make a difference for you. Thank you.